This conference will now be recorded.
Good afternoon to all of you. Today we'll be discussing about thyroid disorders in pregnancy. So this is a thyroid gland. You can see this is the position where the thyroid gland is located. C5 to T1. And if you take a cut section of thyroid, that is a microscopic picture, you can see these are the follicles, right? These are the follicles. A follicle is a functional unit of the thyroid gland. And you can see a deeper picture. So this is the luminant side of the follicle. This is the basal side. So if you take this follicle, this will be the luminal side, this will be the basal side, right? And these are the cells which are present around the follicle. So before going to thyroid disorders, you should know what is happening and how the T3, that is the thyroid, T3 and T4 hormones are secreted. So a simple, I'll tell you in a simple way so that you won't get confused. So you know that iodine, that is iodide, I minus, that is comes from the diet, right? Whatever we take, or the salt in most of the places, what the salt we take is iodized salt, right? So that we don't get thyroid problems in our life. So they mix up iodide. So iodide which is taken, it is absorbed in the gut, and through the blood vessels it comes to the thyroid gland. So what happens in thyroid gland? If you see, this is a thyroid gland, this is a follicle, no? You can see these are the capillaries. So where the iodide comes here, and this iodide is taken into the follicle. So this is the cells, this is a cubicle cells. So around this is the follicle. The structural unit of the thyroid is follicle. You can see these are the cubicle cells, this is the nucleus, and this is the apical membrane, and this is a basal membrane. So the iodide which is present in the diet, it is taken up by the follicle. So because there are, so it is actively transported into the follicle. So actively transported into the follicle by what? By your sodium also. So with the sodium it goes into the follicle, and then iodide is present. So it is into the follicle. You can see iodide form goes into the cell. This is a cubicle cell, right? This is the lumen of the follicle. So this is the cuboidal cell, and this is the blood vessel. So from the blood vessels, iodide comes, actively transported with help of sodium, and then iodide pool is formed. So there is a enzyme called as thyroid peroxidase. It is very important. So this thyroid peroxidase, what will do? It will convert the iodide form to iodine, I minus to I2, that is iodine, right? So and there is enzyme. So iodine is formed. And next, you know that in a cell there are genes, right? So in cell there are genes. So there are genes. So there is a gene. So genes will have, here there will be a specific type of gene will synthesize mRNA. So mRNA synthesizes with help of ribosomes, right? And the mRNA will be used to form protein. So used to form protein. So the protein is nothing but, here in thyroid gland, what type of protein is formed? Protein is full of amino acids. In amino acid, the tyrosine residue will be more. In case of a protein which is synthesized in the cubicle cell of the thyroid gland, with the help of mRNA, protein is formed, and this protein will have different amino acids. So most of the amino acids will be tyrosine, right? So that amino acid will be packed in the Golgi apparatus into packs like this. Okay, these are the into vesicles, right? So that protein is nothing but thyroglobin. So that is nothing but thyroglobin protein. So this thyroglobin protein will have tyrosine residues, more of the tyrosine residue. So it is packed into the vesicles, and through a process of exocytosis, it is released into the lumen, that is into the colloid, lumen of the follicle. So first I told you that iodide, it's coming into iodine, with the help of thyroid peroxidase. It is thrown into lumen of the follicle, and then with the help of ribosomes, mRNA synthesized with help of it. The thyroglobulin protein is synthesized, which has more of tyrosine residues, right? So after that, what happens? So this thyroid peroxidase is very important. So thyroid peroxidase helps in the conversion of iodine to iodine, one thing, and the second help, that is what the second thing that thyroid peroxidase does is, I told you, iodine is there in the lumen, and then your tyrosine, that is the protein, the thyroglobulin protein, which has more of tyrosine residues are there, no? This iodine, I2 molecule goes attached to the tyrosine residue, right? That with the help of thyroid peroxidase. So this iodine goes and attaches with the tyrosine residue. So when this iodine gets attached to tyrosine residue, if one iodine is get attached to one tyrosine residue only, and another iodine is attached to the tyrosine residue, it is called as diiodothyroidine. Only one iodine residue is attached. Only one iodine molecule is attached to tyrosine residue, it forms monoiodotyrosine. So when two iodide molecules are attached, it is called diiodotyrosine. When only one molecule is attached, it is called monoiodotyrosine. That is with the help of thyroid peroxidase. Other third thing what thyroid peroxidase does is this coupling. What is the coupling? That is the, if there is coupling of monoiodothyroxine to monoiodothyroxine, it's called diiodo. If monoiodothyroxine couples with diiodo, it forms triiodothyroxine. So if diiodothyroxine coupling with diiodo, it forms T4. That is so T4 and T3 is formed in that way with the help of thyroid peroxidase. Okay, now which is active form of thyroxine? It is T3. T3 is active form of thyroxine. So T4 is converted to T3 by deiodase enzyme. So this is a simple thing you have to know, how the thyroid gland helps in the formation of thyroid hormones, that is T3, T4. Okay. So which one will stimulate? You know, the TSH, that is thyroid stimulating hormone, is also called as thyrotropin. So this thyroid stimulating hormone, which is comes and attached to the thyroid TSH receptors in thyroid gland and stimulates the formation of thyroid hormones T3 and T4. So this is basically how the T3, T4 is secreted, right? So free form is this. Most of the thyroxine T3, T4 is in the bound form. Bound form is when these hormones get attached to the TBG, that is thyroid binding globulin, TBPA, transthyretin, or albumin. So two, three structures, T3, T4 goes and attached to thyroid binding globulin, transthyretin, and albumin. Free form is very less, 0.03 and 0.3. So T3 is a more active hormone than T4. So free hormone is there. So only unbound, it is free hormone. It is the free hormone which is there is only metabolic, because when it is bound to something, it is not active, right? So when it is free only, it will be active. Same thing. So the free hormone has metabolic activity and has physiological effects. So free hormone is a tiny percentage of the total hormone in plasma, but 0.03 T4 and only 0.3% in case of T3. The total hormone concentration, normally it is proportional to carrier proteins, is kept in appropriate to maintain the constant free hormone level. So what happens when there is increase of TBG, thyroid binding globulin, when it is increased, what happens? Total T4 and T3 levels. When this hormone is increased, the amount of T3 and T4 total is increased, but the unchanged, that is the free hormone. So what happens is the body always try to maintain free T3 and free T4 levels. So because this is the free T4 and T3 are those which are metabolically active, so the body tries to maintain these levels, normal levels. So when there is TBG increase, the total T3, T4, the bound form of thyroxine increases, but the free levels doesn't change. Okay. When this decreased also, when TBG is decreased, total T3, T4 will decrease, but free T3, T4 will remains unchanged. So that's what body does, right? So these are things, the drugs which increase the total thyroid binding globulin and drugs that increase. So increase, we know that in pregnancy increases and infections, right? These you remember, and decreases OCPs, which are source of estrogen or other source of estrogen. They decrease TBG. These 2 points remember at your level. Next, this is okay. So I told you T3 is more potent than T4, almost 3 to 8 times more potent, and half-life of T3 is only 1 day and T4 is 7 days. And 20% of all circulating T3 originate from thyroid, and other 80% produced by liver, kidneys, and other target cells that cleave iodide from T4. So I told you 20% directly from thyroid gland. Another one from T4 is converted into other organ target organs. Where see, thyroid is a hormone which is required by every cell in the body. So the thyroid goes to every cell and act because it is important for the maturation, that is the mental maturation, physical maturation, for the basal metabolic rate of every cell. Your thyroid is required. So about 20% of the active, that is T3, is produced directly from thyroid, and another 80% is produced from conversion of T4 to T3 by taking the iodide, that is the deiodase enzyme. The conversion of T4 to T3 is catalyzed by microsomal 5-deiodase enzyme, which removes iodine from 5th position of the outer ring. Okay. T3 is therefore the more potent hormone, while T4 is mainly ascribed to storage function plasma. So now coming to our in pregnancy. So thyroid disease in pregnancy is overlooked because the symptoms of hypothyroidism, symptoms of hyperthyroidism, really all they overlap with the symptoms of pregnancy. So abnormal thyroid function adversely affects the maternal as well as fetus or the fetus. So what are the maternal changes in thyroid physiology? So what happens during pregnancy? You know, in pregnancy, what happens? The requirement of every micronutrient or every protein and everything is increased, right, in pregnancy. So there is also here the dietary requirement of iodine is increased in pregnancy, and also because of this, the placenta is the organ which will take all the nutrients from the mother to the fetus. So there's increased transplacental uptake of iodine in pregnancy, and also increased maternal renal clearance. So GFR is increased, and your because GFR is increased, your iodine is also excreted, and also in placenta is there in pregnancy, which in placenta there is it is produced deiodinase enzyme is produced, which will convert T4 to T3. So the active form is increased. So all this is result will increase in hormonal synthesis because of increased requirement, because of everything. What happens? The hormone synthesis is increased, and iodine uptake is also increased. So the recommended daily allowance in non-pregnant 150 micrograms, in pregnancy it is increased 175, lactation still is increased. So the requirement of iodine is increased. So in pregnancy, what happens is there is raise in TBG, thyroid binding globulin is increased in pregnancy. That you have to know, because the estrogen induced stimulation of synthesis from liver. So from the liver, thyroid binding globulin is produced, and that is the reason why, because more estrogen in pregnancy, TBG is increased. Thyroid binding globulin is increased. So when thyroid binding globulin is increased, what happens? The total bound form, I told you when it is increased, total amount of T3, T4 is increased, but the free T4, T3 remains unchanged. But what happens in pregnancy is, this is normal, what happens now when amount of TBG is increased, the bound form is increased. So the total T3, T4 is increased, but the free T4 and T3 are not increased. But what happens in pregnancy? There is HCG, which is produced from the placenta, right? From syncytial trophoblast, HCG is produced, right? It is from the placenta. So when HCG is produced, how many units are there in HCG? Alpha and beta subunits. The alpha subunit of HCG will be similar to the alpha unit of THC. So there is similarity. So the alpha subunit resembles to the subunit in TSH. So what happens? This HCG goes through the placenta into the maternal circulation. Okay. So through the maternal circulation, what happens? The HCG will go and stimulate what? The maternal thyroid gland, because its alpha subunit was similar. So when it thinks that TSH has come and asked the thyroid gland to get stimulated, so it thinks that it is an order, and then what happens? The maternal thyroid gland will secrete more amount of thyroid hormones, T3, T4, right? So there is free, there's elevated free T4 levels in the first trimester. And because of this elevated free T4 levels, the TSH will decrease. TSH will decrease in the first trimester of pregnancy. I think you have understood now. So normally in pregnancy, thyroid binding globulin is increased because of estrogen induced stimulation from the liver. And because of that, what happens is the total amount of thyroxine hormones are increased, that is total T3, T4 are increased, but the free T4, T3 are unchanged. But in pregnancy, what happens is, though TBG is increased, the HCG which was raised, because HCG peaks in about 10 weeks, almost about 12 weeks HCG is produced, peak is about 10 weeks. So when there is HCG, the alpha subunit of HCG is similar to TSHs. It passes through the placenta, goes through the placenta into the maternal circulation, and goes to the maternal thyroid gland to stimulate the thyroid gland of the mother, and the free T4 is increased. When the free T4 is increased, what happens? There is a feedback mechanism. No, yes, more amount of T4 is increased because T4 is metabolic active. It only can go and tell to the pituitary that okay, more amount of thyroid hormone is used, please stop secreting TSH. So what happens is elevated free T4 will go and tell the hypothalamus to decrease the secretion of thyroxine releasing hormone and decrease of TSH from the pituitary, and then decrease of TSH. So that is when the first trimester, about up to 12 weeks, peak in about 10 weeks, your TSH will be less. Okay. So this is very important. Why the body it is important is because it is for the fetal development, important role in placental development and trophoblastic invasion. So here there is biochemical hypothyroidism in third trimester with slightly elevated TSH and fallen free T4. This is in the third trimester. This is not important, right? You can see here first trimester, second trimester, third trimester. No, so first trimester your TSH will be decreased. Here again returns to second and third round. So the in first trimester, if you take a TSH value, you can see the TSH also is decreased more than what you expect. T4, T3 are increased. All are increased, right? Total, because total amount of T4, T3 is because of thyroid binding globulin is increased in pregnancy. If you take free T4, T3, everything maintains to be normal. HCG is increased. So here in first trimester, the T4 will be more. That is not there here. Okay. So fetal thyroid usually developed almost 18th week, almost 18 to 20 weeks, your active hormone synthesis will start from thyroid. Though around 20 weeks, the fetus starts to secrete hormone synthesis, the fetus depends upon the maternal thyroxine. So almost about 30%, 30% will be required from the maternal side. Though the fetus starts producing, it is not sufficient. So how do you evaluate? So when you do a TSH, if it is low, then you think of hypothyroidism. Then you order free T3, T4 is important. If it is normal, because TSH is low, free T3, T4 is normal, you name it as subclinical hypothyroidism. If it is high, hyperthyroidism. Suppose if TSH is low, high, it is, you know that if TSH is a hypothyroidism, you order free T4. So this is hyper, okay, this is spelling mistake here. So this is HER. So when it is normal, it is so when T4 levels are normal and your TSH is high, it is subclinical. When TSH is high and T4 is low, it is called hyper. So I told you in the metabolism of thyroid, you saw thyroid peroxidase is very important enzyme. So when there is a problem in the thyroid metabolism, so these can be there to, we have to evaluate. So what are the important things? Thyroid peroxidase antibodies. So the peroxidase enzyme is not working. I told you peroxidase is important in 3 steps, right? So when there is antibodies to this thyroid peroxidase, those 3 steps cannot be there. When those three steps are not there, what happens? Your hormones are decreased. T3, T4 it doesn't produce. And thyroglobulin antibodies. You know what is thyroglobulin? It's a protein, right? So antibody to that is the tyrosine residue is only not there when there are antibodies to thyroglobulin. Next, thyroid receptor antibodies. Okay. So the TSH comes and attached to the receptor. No, that is not functioning. So it won't obey the command of TSH. It is thyroid receptor antibodies and thyroid receptor stimulating antibodies. So when you more amount of stimulation is there, more amount of thyroxine hormones are produced, which lead to hyperthyroidism. Then thyroid receptor blocking antibodies. So these are the antibodies that you should evaluate when major degree of hypo or hyper is present. Next, coming to thyroid disorders in pregnancy. So it is second most endocrine dysfunction, and it's a problem for women. And most common hyper and hypo, but most often we see hypothyroidism in pregnancy. Overt hypo occurs in 1%, subclinical in 2 to 3% of the cases. Hyperthyroidism occurs in 0.1 to 0.4. So what are the causes of hypothyroidism? So Hashimoto's thyroiditis, dequerens thyroiditis, iatrogenic when any surgery was done, and any previous history of radioactive iodine uptake, iodine deficiency in some endemic areas, and any infiltrative diseases, congenital hypothyroidism. So these are causes for maternal hypothyroidism. Then what are the investigations? So you have to do free T4, T4 in pregnancy. That is important. Not only TSH, free T3, T4 levels. So if it is hypothyroidism, TSH is increased, free T3, T4 are decreased. If it is subclinical, these levels will be normal. Free T3, T4 will be normal and TSH is increased. Okay, that's all you remember for maternal hypothyroidism. So how can they present? So the very vague symptoms, and usually some asymptomatic patients can be there just as routinely you write a thyroid test and you just diagnose it as hypothyroidism. And what are the symptoms like fatigue? So some people can tell you she has fatigue, hair loss, dry skin, excessive weight gain, despite poor appetite, weight gain despite poor appetite, cold intolerance, unusually seen in pregnancy. So usually in pregnancy, what happens? The basal metabolic rate increases and she feels very warm and she'll be sweating. But contradicting to that, if she tells that she's having cold intolerance, then you have to suspect hypothyroidism. Muscle ache, stiffness, paresthesia, carpal tunnel syndrome, pulse rate inappropriately slow for pregnancy. So usually pulse rate will be more, but in hypo, pulse rate will get decreased, and delayed relaxation of deep tendon reflexes. So gross mixed edema, periorbital edema, large tongue, hoarse voice are exceptions. And so why we are worried? If she's having hypo, what are the problems? So usually if she's having major degree of hypo, usually she'll have a history of prolonged infertility and she'll be having recurrent abortions. And during pregnancy, she can land in preeclampsia, PIH, she can land in abruptio, she can land in PPH, anemia. So more serious and rare complications, mixed hematus, coma. And what are the fetal risks? So fetal risk of miscarriages, IUGR, IU. So she can land in stillbirth. Okay. Low for gestational age babies, low birth weight, neurodevelopmental delay. This is very important. Neurodevelopmental delay is very problem in the fetuses. So how can you manage pre-pregnancy? So she's not pregnant, but before she has diagnosed. So you have to start TSH. So before pregnancy, if her thyroid is under control, she will not have any complications. So 4 to 6 weeks interval, the TSH should be measured and adjusted. The dose should be adjusted by, don't increase the dose too much at a time, 25 to 50 micrograms. You have to adjust until TSH is less than 2.5. This is for the first trimester. Usually in the first trimester, the TSH level should be between 0.5 to 2.5 milli international units per ml. So this is so, if she's not pregnant, no, if she's not pregnant, then this value will be more. So usually more than less than 5 is normal in non-pregnant women. But in pregnancy, the cutoff is at a lesser level. Why? Because I told you what happens in pregnancy because of HCG. So you have to maintain between 0.5 to 2.5 milli international units per ml. All right. So increased thyroxine requirement begins as of 5 weeks itself. Okay, and you have to monitor thyroid profile every 3 months, and free T4 is a better indicator. Okay, and when you prescribe drug for suppose she was hypothyroid, you prescribe thyroxine. Iron, calcium, and antacid, they interfere with the thyroxine and they should be taken different. And that's why we tell the patient as soon as she gets up in the morning and after she brushes her teeth, she has to take the thyroid tablet. And if any tablet she wants to take, the gap between the two tablets should be at least be 1 hour. So she should be taken at different time. And you have to check compliance of vomiting. So she should not vomit after taking the tablet. If she vomits within 15 minutes, she has to take another tablet. So breastfeeding is safe. During labor, what are the problems is, they can cause anesthetic complications. That is the problem. That is why before surgery, always anesthetist wants a thyroid report to be done. Okay. So postnatally, you have to observe a postpartum thyroiditis and screen for postpartum depression. All neonates are screened for hypothyroidism via heel prick on 6th day of life. On 6th day of life. Then subclinical thyroidism. Subclinic is nothing but TSH is raised, other hormones are normal levels. Okay, you also see in pregnancy 1.7 to 2.3% of pregnant women will be there. Risk of progressing to overt hypothyroidism during pregnancy in otherwise healthy women seems unlikely. So does not warrant treatment as complication rate is similar to the rest of the population. If subclinical hypothyroidism is there, usually you can you need not start treatment to the patient. Then coming to maternal hyperthyroidism. Hyperthyroidism is very less common than hypo. Causes are autoimmune, subacute thyroiditis, acute thyroiditis, dequerent thyroiditis, postpartum thyroiditis, thyroid tumors, toxic nodal gland, toxic adenomas, okay, iatrogenic because of your drugs, gestation trophoblastic disease, and pituitary adenoma. So these are the conditions when a patient presents with hyperthyroidism, you have to exclude all these conditions. And what is the here pathophysiology is the thyroid stimulating autoantibodies. So there is organ specific process by thyroid stimulating autoantibodies. So naturally causes exacerbation of symptoms in the first trimester and during the postpartum period and amelioration of symptoms in the second half of pregnancy. This is what happens. Here the patient, usually pregnant patient will tolerate mild hyperthyroidism. And the diagnosis same way, it is difficult because all the symptoms of the pregnancy overlap the symptoms of hypermetabolic state of pregnancy, and the symptoms will be nervousness, irritability, change in personality, increase of appetite. She'll be sweating a lot, she cannot tolerate the heat, and she'll have sleepless nights, and she cannot hold anything, right? She cannot lift her hand. There is proximal muscle weakness will be there. She cannot even comb her hair properly. So all this will be there. So persistent tachycardia greater than 100 per minute, and weight loss will be there, and eye changes will be there. So tachycardia will be there, persistent tachycardia greater than 100 per minute. Tremor will be there. Maternal hyperthyroidism. So pregnancy outcomes. So why again think what is the problems during pregnancy when a mother, when the pregnant mother will have hyperthyroidism. So what are the problems she might get during the course of pregnancy? So she can land up in preeclampsia, she can land up in heart failure, she can be present of thyroid storm, which are all very cause for maternal death. So in fetus, how they are going to affect. So the fetus can have intrauterine growth retardation, preterm stillbirths, fetal hypothyroidism, and fetal hypothyroidism. So what happens here, there is how the fetus will get affected is, you think the mother is having hyper, how the fetus can affected is, because there is a placenta between the mother and fetus, so this thyroid stimulating antibodies go in through the placenta into the fetus, and they cause problems in the fetus, which results in preterm labor. And what are the other cross problems are, the development of structural problems, fetal craniosynostosis, There can be fetal exophthalmosis, heart failure in the fetus leading to hydrops fetalis, hepatosplenomegaly, so thrombocytopenia in IUGF. So very gross problems in the fetus. And there'll be after the birth, the baby can have jaundice, poor feeding, poor weight gain, and irritability. So, and mortality is as high as 20% in the baby. So, maternal autoantibodies test in the first trimesters and at 6 months. We have to test if high titers are detected or if levels have not fallen at 6 months. Fetal thyrotoxicosis anticipated and antenatal screening with ultrasound is done to assess fetal growth and fetal heart. So you have to be very careful when the levels are not, the titers are not decreasing. You have to assess the growth of the fetus very cautiously. Okay. So fetal hypothyroidism will have neurological damage. And the fetal exposure to maternally administered antithyroid drug. Treatment is decreased maternal antithyroid dose. So when the more amount of antithyroid dose is there also, the mother can land up in hyperthyroidism. So how do you manage? The optimum control is by drugs, surgery or radioactive iodine. Pregnancy delayed for at least 6 months after radioactive exposure. So when the mother is exposed to some radioactive thing, she has to delay her pregnancy for at least 6 months because she can land up in hypothyroidism. In pregnancy, there are two treatments, medical and surgical thing. Here, what are the anti-thyroid drugs? So in hypothyroidism, you give only Eltrox. So in hyperthyroidism, there are two drugs, propylthyrouracil and carbimazole. Which is most preferred? Propylthyrouracil is most preferred than carbimazole. But if she is on carbimazole, you need not shift to propylthyrouracil. But you want to prefer propylthyrouracil. So T half is 1 to 2 hours. Carbimazole is 4 to 6 hours. Duration of action is about 1 day. It is almost 12 to 24 hours attack, so 1 day course. This is more amount. T duration of action is greater than 24 hours. The serum protein binding is almost 75% here. Starting dose is 100 to 200 mg, 6 to 8 hourly, and then you can increase the dose to 3 times a day. So yeah, this is 3 times a dose. So first you have to start 3 times a day, maintenance 3 times a day. Here carbimazole, because its T-half is more, you can start BD and then maintain to OD levels, that is once a day. Available is a 50 mg tablet. This is 5, 10 and 20 mg tablets, and both are category 2 drugs. So carbimazole dose is low because 50 mg of propylthyroxine is equivalent to 5 mg of carbimazole. So the dose of propylthyroxine is more than carbimazole. Medical management will have all these side effects. So your drugs will have these side effects. So I told you propylthyroxine is preferred than carbimazole, and you have to repeat after 4 weeks, and should be the upper limit of normal. Okay, and T4, free T4 is a better indicator than TSH always. And when the patient is more symptomatic, like she's having palpitation, tremors, and everything, you have to start beta blockers. But when you start beta blockers, what is the problem? Long-term use, the baby can become IUGR baby. Surgical management very rarely indicated in pregnancy. So when there is failure or intolerance to drugs, or you suspect any carcinoma in the thyroid, or when there is a large goiter which is compressing over the trachea and esophagus, for her it is very difficult to eat and for her it is very difficult to breathe, then only you can opt for surgery, and ideal time for surgery in pregnancy is your second trimester. So radioactive iodine should not be used in pregnancy because it causes permanent damage and can lead to reverse hypothyroidism. So if pregnant, don't use. If used and you later know that she's pregnant, just terminate the pregnancy. Okay. So subclinical hyperthyroidism, you know that again this free T3 T4 will be normal, TSH will be decreased. So usually not associated with adverse outcome. Even subclinical hyper and subclinical hypo are not associated with adverse outcome, and no convincing evidence for its treatment, may benefit from periodic surveillance. So no need of treatment in these cases. So thyroid storm. So thyroid storm is another thing which is an emergency. It is a life-threatening hypermetabolic state. The patient will have palpitations, tachycardia, atrial fibrillation, high output cardiac failure, fever. She'll have restlessness, confusion, psychosis, seizures, and coma. diarrhea, vomitings, everything will be there in this patient, and the patient goes into failure, high output dilated cardiomyopathy, and it is often reversible. And so all the patients won't land up in thyroid storm. So what are the patients which land up in thyroid storm are when there are precipitating factors. The precipitating factors are preeclampsia, anemia, and sepsis. So in pregnancy, if she's having a thyroid problems, you have to monitor the patient. You have to correct anemia. You have to correct any. You have to diagnose early if she is having any hypertensive problems, and she should not land up in sepsis. Simple UTI. So simple urinary infection also can precipitate. That's why you have to see that the patient will not have any infections, urinary infections, any upper respiratory infection. All that can precipitate thyroid storm in the patient. Very careful. Then how do you manage? Intensive care admission with supportive therapy. You should start a beta blocker. You should start antithyroid drug, dugolzidine, and steroids. And whatever the reason for this precipitation of thyroid storm, you should get treated. So another thing is, because today we have talked about thyroid disorders, you should know about gestational thyrotoxicosis, which is in hyperemesis gravidarum. So usually the abnormally high levels of thyroxines will present. I told you T3, T4, T4 will be high, and low level of TSH will be there in the first trimester, right? So cause is TSH receptor stimulation are massive but normal for pregnancy because of HCG, because of alpha subunit residual goes and stimulate the thyroid receptor in the maternal thyroid gland, and then T4 will be increased and then TSH will be decreased. This is in case of normal gestation. So here there is a correlation between vomitings and hyperthyroidism. That was the thing. So there is transient course of transient hyperthyroidism of hyperemesis gravidarum. So these are not important. This is important, right? This you have to remember. So in the first trimester, second trimester, third trimester, these are the, so whenever the patient comes in first trimester, TSH levels should be less than 2.3, max than 2.5. So this is a cutoff, 0.03 to 2.3. Okay, second trimester 0.03 to 3.7. Third trimester again 3.4. Okay, this is free T4 is important. So free T4 levels are, these are normal values. It is nanograms 1.77 here, 1.29 maximum, and 1.12. So these values are important. First trimester less than 2.3, second trimester less than 3.7, third trimester less than 3.4. You have to maintain. Thank you for the patient hearing.